Hello, and welcome to Special Populations, SBIRT and Marijuana Use, and SBIRT and Women of Childbearing Age. This webinar is hosted by NORC at the University of Chicago, the BIG Initiative, the Brief Intervention Group, and the National SBIRT ATTC. I'm Tracy McPherson. I'm your webinar facilitator today. I'm a senior research scientist at NORC at the University of Chicago, and I co-lead the Brief Intervention Group, the BIG Initiative. You are welcome to contact me at this contact information at this email. If you have any questions following the webinar, if you'd like to talk or learn more about the Brief Intervention Group and the work that we're doing with the National SBIRT ATTC, to move screening, brief intervention, and referral to treatment into routine practice across various systems, some of the systems of which we'll be hearing much about today. I would encourage everyone to learn more about the National Screening, Brief Intervention, and Referral to Treatment ATTC, or fondly known as the National SBIRT ATTC. This webinar is part of our monthly Webinar Wednesday series. So I encourage you, we'll have the website address for you later, to go to the website and learn more about the webinars that will be coming up in August. We'll have a further webinar that will be talking in more depth about marijuana SBIRT and implementation and guidelines that have been used. And we will have a full schedule including webinars in September, and our next grant year beginning in October will be posted soon. We encourage you to register for those, and you can also listen to archived webinars that we've already hosted. And so please take advantage of those resources and other kinds of free resources made publicly available to you through the National SBIRT ATTC. We have two presentations today. The first presentation on special populations will be presented by Bree Ryman. Following her presentation, we're going to open it up for questions. We'll take a few questions through the chat feature. Hope you can see that there's a questions pane, and you will be able to, using your keyboard, type in your questions there, and we'll be fielding, probably half a dozen or so of those questions. If you have additional questions that we don't get to, you're more than welcome to contact me. You'll also get the contact information for Bree Ryman, and you can contact her about her webinar as well. Following Bree, we have Jen Shepard. She'll be presenting on SBIRT and Women of Childbearing Age. We will also pause after her presentation and open up for questions specific to what she'll be talking about. And if we have any additional time and you hadn't had a chance to answer, get some of your questions answered, we'll go back and try to get some of those if we still have any time remaining. And if you have any questions about the question box, you can certainly use your chat feature if something is not functioning or having difficulty. We have Misty on the line who is hosting our webinar, and she'll be able to help you if you have any technical difficulties. So welcome to Special Populations, SBIRT and Marijuana Use, and SBIRT and Women of Childbearing Age. Our first speaker is Bree Ryman, and she is the Director of Policy and Development at Peer Assistance Services, Inc. As the Director of Policy and Development, Bree works to advance the role of substance use prevention and early intervention in Colorado's rapidly changing healthcare environment. Over the past several years, Bree has worked as a Director of the Screening, Brief Intervention, and Referral to Treatment, or SBIRT initiative, funded by SAMHSA, providing guidance to hospitals, primary care settings, federally qualified health centers, or FQHCs, employee assistance programs, and other community-based settings on integrating routine substance use screening and brief intervention services as a standard of practice. Through this work, Bree has learned that substance use disorders continue to be highly stigmatized health concerns, and that in order to adequately prepare providers to have meaningful conversations with patients, ongoing education, skills training, and support is necessary. Ms. Ryman serves as a on the steering committee on Colorado's Behavioral Health Planning and Advisory Council, and serves as the chair for the Prevention Committee. She received a Master's of Public Administration from the University of Colorado at Denver with an emphasis on healthcare policy. So join me in welcoming Bree Ryman. Bree, I will hand it over to you.
Thank you, Tracy, and thank you all for joining the webinar today. I'm glad to be presenting to you on SBIRT Colorado and special populations. I'm going to start the presentation today just giving a brief overview of the SBIRT Colorado initiative and some of our lessons learned that we've gleaned over the past 7 years of implementation in Colorado. And then I'm going to pass it over to Jennifer Shepard with Omni Institute to talk about some protocols that we've recently implemented to our SBIRT initiative to focus specifically on women of childbearing age and to address the marijuana issue in our state. So I'm going to start just by giving a little information about SBIRT Colorado. In Colorado, we received the Screening Brief Intervention Referral to Treatment grant from the Substance Abuse and Mental Health Services Administration in 2006. This is a 5-year grant, and we have since received another 5-year grant in 2012. So we're in a unique situation in that we will have received 2 consecutive grant awards from the Substance Abuse and Mental Health Services Administration, or SAMHSA, to implement SBIRT for 10 years. So we've had quite a lot of experience working with, as Tracy mentioned, primary care settings, federally qualified health centers, trauma settings, emergency departments, dental clinics, HIV care settings, HIV prevention settings, and employee assistance programs. And our goal with SBIRT Colorado is really to integrate routine screening and brief intervention as a standard practice in all different kinds of healthcare settings. What we've found from our experience is that oftentimes when we go into a healthcare setting and talk with the healthcare providers, they mention that they're doing some type of screening and brief intervention, but when we really get down to it and look at the electronic medical records and evaluate the screening questions, they're not questions that are validated or evidence-based. So what we do is we retrain healthcare providers to administer screening questions in a way that are true to the evidence and to address the issues of substance use and oftentimes depression and other healthcare issues as routine practice. And in our state, you see here a slide that says, "Welcome to the Mile High City." We have some unique challenges. As you may know, we recently passed legislation to legalize marijuana for recreational use among adults. That presents some unique challenges in our state, and what we're learning from healthcare providers is they're really looking for a way to provide good information to patients about the health risks associated with any marijuana use, whether or not it is for medical use or for recreational use. So we're working on training providers on having meaningful conversations with patients around the risks of marijuana use. And you'll see from Jen's presentation shortly some of the data that we've collected. We've implemented some new protocols in our SBIRT efforts to really focus on the issue of marijuana use. And Jen will be presenting a little bit on that information as well. And so what else with our state that you might want to know? We have consistently been in the top 10 for high-risk substance use for many years. And related to that, we're also, I believe, 48th out of the 50 states in terms of what we spend on treatment of substance use disorders, and even lower on that scale for what we fund for prevention efforts. So we have often been in a situation where we don't have enough resources to address the issue of substance use disorders. So this SBIRT funding that we have had for now 7 years has really helped us to change the system so that we can adequately begin to prevent and provide early intervention services to address substance use as a routine part of healthcare. And so with that, I'm going to talk a little bit more specifically about our efforts here under our SAMHSA-funded initiative. So as I mentioned, we've been funded since 2006 now to implement SBIRT in healthcare and other settings. These are our 3 main objectives with these funds. They include to disseminate SBIRT as a standard practice in all different types of healthcare settings so that it just becomes routine part of care. We want to see that patients are asking their providers, if, why aren't you screening me for my alcohol use if they're not screened for that, so that it just becomes an expectation. Just as you get your blood pressure screened, you're also going to be asked about your substance use. In Colorado, we promote the use of evidence-based screening tools that look at tobacco, alcohol, and the misuse of prescription medications and also illicit drug use. So we're, even though the evidence around SBIRT mostly is seen around screening and brief intervention for alcohol use, we in Colorado have taken the approach that if you're going to screen for alcohol use, you might as well screen for illicit drug use as well. In our state, we have this increase in the misuse of prescription medications, and so it's really important for us to be looking at that as well. And because of the polysubstance use that we often see happening with our patients, we want to be seeing the whole picture of what's going on with the patient and how their substance use may be interacting with their health, and then provide the conversations necessary around behavior change related to substance use. Our second goal is to improve linkages between primary care, mental health, and substance use disorder treatment providers. What we've learned from these 7 years now of implementation is that there's often a breakdown in communication between the physical health care and the behavioral health care. So what we want to do is we want to build the relationships and strengthen those relationships between the provider sectors so that patients are not falling through the crack. If we do identify somebody who needs treatment within a healthcare setting, we want to make sure that they have all the resources they need to make that step to get to behavioral health treatment, and then to close that loop so that the healthcare provider is learning of the outcomes of the treatment, should that be necessary for patients. Our third goal is to really institutionalize SBIRT as a standard of care through state-level system and policy change in alignment with healthcare reform. In our state, as I'm sure in many of states across the nation, we're seeing a lot of transformation happening within the healthcare system due to healthcare reform. And so we're really trying to align our screening and brief intervention efforts with what's happening in that changing environment. So in our state, in Colorado, we have regional care collaborative organizations, also known as RICOs, that are being established in different regions across our state, and they're really charged with managing care in each region, healthcare and behavioral healthcare needs. And so we're trying to really work with the RICOs as they're being established to institutionalize SBIRT within these systems. Our partners include the Office of Behavioral Health, and the SAMHSA grant was awarded to the Governor's Office, and the Governor's Office then contracts with the Colorado Office of Behavioral Health, and they manage our publicly funded substance use disorder treatment providers in our state. They license the substance use disorder treatment providers. So the Office of Behavioral Health contracts with peer assistance services to manage the implementation of the SAMHSA SBIRT initiative across the state. We're a nonprofit organization in Colorado, in Denver, and we focus on providing prevention and early intervention services statewide to mostly adults living in Colorado. And so peer assistance is responsible for managing the SBIRT funds, and we contract with several different primary health care settings across the state to integrate SBIRT into practice within the 5 years of funding that we have. And we also collect data. So we contract with these settings, and the settings hire health educator positions. And the health educators are charged with routinely screening and providing brief intervention services universally within these healthcare settings. The goal of the health educator position is also to help to transform that practice, to really institutionalize SBIRT. So what we want to see after the 5 years of the SAMHSA support is that this just becomes part of the healthcare practice within the settings that we're working with. And then with a broader goal of across the state, SBIRT just becomes routine part of healthcare. So Peer Assistance works closely with all different types of healthcare settings to implement SBIRT with these funds. We also work with Omni Institute, and Omni Institute is our lead evaluation firm out of Denver, and they are responsible for really collecting the data. We've built a database that the health educators use to collect the data on the screening and brief intervention. We use the ASSIST screening tool, or the alcohol, smoking, and substance involvement screening test, and also all the GIPRA data that SAMHSA requires for us to report our outcomes. And they do a lot of other evaluation projects that Jen will talk about in a moment. We work with Minds and Associates, which is an employee assistance program. It's a national firm, and we work with Minds and Associates to really coordinate the wellness coaching. We call it wellness coaching. You'll often hear it referred to as brief therapy or brief treatment for the patients that we identify in the healthcare setting. So if the health educators identify a patient who needs further services other than just a brief intervention that's occurring in the healthcare setting, then the health educator contacts Minds and Associates to provide some wellness coaching over the phone and in person, and then possibly a referral to specialty treatment should a patient need that. So what we found with the first 5 years of SBIRT funding is that oftentimes we were partnering with a substance use treatment organization and referring patients from healthcare to treatment, but they were often not showing up, so they were falling through the cracks. And with our new round of 5 years, of the 5 years funding that I mentioned that we received in 2012, we decided we really needed a solution to this. We needed to do a better job of identifying ways to really encourage that patient to make that next step to engage in treatment should they need that. And so Minds and Associates was an effort of ours to close that loop, to assist that patient and make sure they have all the resources they need to make it to treatment. We also work with an organization called Health Teamworks out of Denver, and they were formerly called the Colorado Clinical Guidelines Collaborative. And we contract with Health Teamworks to develop a clinical guideline on SBIRT. And I believe I have a slide coming up here that will demonstrate what the guideline looks like. And Health Teamworks developed the clinical guideline to train primary care practices to integrate screening and brief intervention into care. So they go on site and they provide what's called a rapid improvement activity, a brief training with the entire primary care practice around implementing SBIRT. And the guideline is a 2-page laminated guideline, and Health Teamworks really coaches the clinic on integrating these services into practice. We also work with Advocates for Recovery, and Advocates for Recovery, or AFR, is a recovery service provider in Colorado, and they really provide resources to patients that are identified in recovery through our SBIRT processes to provide support to the patients that are identified as in recovery. So we try to address the full continuum of substance use across the continuum in every aspect of our SBIRT work. So we've tried to really partner with the experts that are experts in prevention all the way to experts in recovery. So you'll see here a snapshot of our guideline for alcohol and substance use screening, brief intervention, referral to treatment. This is our SBIRT clinical guideline. And in addition to having health educators on site at primary care practices, we also spend a lot of our time going out and training primary care, F2HCs, hospitals, all different types of settings on implementing SBIRT. So we kind of have a two-pronged approach to implementation. We have our health educators that are collecting the data for SAMHSA and providing the SBIRT services, but we're also working with sites that are just interested in implementing SBIRT because of certain requirements, such as the American College of Surgeons Committee on Trauma Level 1, 2, and Level 2 recommendations, or the Joint Commission recommendations, or the United States Preventative Services Task Force recommendations around alcohol screening. We get a lot of interest within our state, and I think part of that has to do with just the knowledge that we have these resources available through with the support from SAMHSA. So we've been able to really reach clinics and hospitals and healthcare settings outside of the scope of our SAMHSA grant to really achieve that goal that I mentioned earlier of truly institutionalizing SBIRT across the state and in different healthcare settings. And you know, our state is mostly a rural state, so we've really had to be very flexible with our implementation efforts, because it looks very different in certain areas of our state because of the rural nature of what healthcare and behavioral healthcare delivery looks like in some of our communities. So just to briefly walk through this guideline, and this is available on the Health TeamWorks website, which is healthteamworks.org, as well as our website, which I believe you'll see listed at the end of the presentation, the contact information. We promote the brief screening process, so you'll see listed in Step 1, brief screening. And so the idea here is that the brief screening questions, what we're seeing happen in Colorado, are being uploaded into electronic medical records so that they're routinely asked of every patient that comes through any type of setting. And you'll see that we have quantity frequency questions listed, an illicit drug question that looks at the misuse of prescription medications, and a tobacco question. We're working now to add a new question to this due to the recent legislation in our state that marijuana now is legalized for recreational use. And that question is, in the past year, how many times have you used marijuana? If a patient reports any use of marijuana, whether or not it's medical or recreational, that will indicate a need for further screening. So we're just treating that as looking at how it may impact the patient's health and still having that opportunity to provide a meaningful conversation with the patient around potential health concerns. So these brief screen questions are really institutionalized as being, you know, universally administered. And then if a patient scores positive on these brief screen questions, whether or not they're drinking above the moderate drinking guidelines, or they report using illicit drugs, or the misusing prescription medications, or any use of tobacco or marijuana, then the provider would administer further screening. And you'll see under Step 2 here the tools that we typically recommend for further screening: the audit, the DAS, the assist, the craft, all evidence-based. And based on these tools, a patient's provided a score, and you'll see on the right the low risk, moderate to high risk, and high risk. And based on their score, further services are provided. And we always talk about how the target population and the majority of the patients will score in that low risk to moderate risk range. And that's typically what our data are showing, is that patients score in the low risk category or the moderate risk category. And our target population is really that moderate risk category. So where the brief intervention, that opportunity to have a brief conversation with a patient, can really make a difference around behavior change. And so we do a lot of training with providers on how to have those meaningful conversations around behavior change, brief, you know, within 5 to 10 minutes of having this conversation with patients to hopefully plant the seed around behavior change and to increase health outcomes. And then the back side of the laminated guideline, you'll see your ORs in the top right corner. Those are, you know, the motivational interviewing skills that we typically train on in our state, as just kind of being those skills that you can really grab onto when you're having a brief intervention, and remember the importance of the open-ended questions, affirmations, reflections, and summaries. We found through our experience, just a lesson learned, is that we really, when we're talking to nurses and MAs and physicians around doing brief intervention, that you don't have to be an expert at motivational interviewing. You just have to know the key core skills involved with motivational interviewing, because oftentimes what healthcare providers were reporting to us was, we don't have time to provide an hour-long conversation with our patients. You know, we're charged with seeing so many patients a day, and oftentimes we only have 15 minutes total with a patient. And so we really train providers on weaving this into all of their conversations, not only around substance use, but healthy diet, healthy eating habits, sleep habits, all different kinds of conversations these skills can be incorporated in. So then we have the brief intervention box listed here, and we promote the brief negotiated interview. So it breaks the brief intervention down to 4 simple steps, and so we really train on administering these 4 steps while delivering a brief intervention. You'll see the importance, readiness, and confidence ruler here, and we train on how to use that. And then you'll see some information on how to refer for tobacco. We in Colorado have access to the Colorado Quit line, so typically our healthcare providers refer patients to the Quit line by faxing in a referral form and engaging the patient in the Colorado Quit line services. And then we have some information on brief therapy and treatment on the bottom, as well as reimbursement, which I'll talk about in a minute, and some of the challenges with reimbursement. So this is a map of our state in Colorado. I mentioned that we're mostly rural. One of our biggest goals, one of our main efforts through this funding was to really reach every community that we can, so that there's some type of information of SBIRT available in each community. And so each of these dots, you'll see different colored dots listed here. These all represent areas of the state, communities in the state that we've reached in some form or fashion, whether it means we've funded a health educator on site at a clinic through the SAMHSA funding, so we're collecting the data, or we've trained clinics or practices to implement SBIRT. So currently we have contracts with 6 implementation sites that are collecting the data for SAMHSA, and then above and beyond that we've trained thousands of healthcare providers, mostly nurses, in our state to implement screening and brief intervention. So let me go back one. You'll see here that this represents the first 5 years of data collection in our state. So from 2006 to 2011, we started screening in the Denver Health Emergency Department. So a very busy level 1 trauma center in our state in the Denver metro area. We trained the nurses to administer the brief screen questions, and we had health educators on site to do further screening, brief interventions, and then the referral to treatment piece. We, from there, started working with a variety of other clinics. So during the first 5 years, we worked with 7 hospitals, 5 primary care clinics, and then 1 dental clinic serving patients living with HIV. And so what we saw over the 5 years of implementation, and we screened about 115,000 patients, we found that typically, I mentioned earlier, that patients were really falling in that low risk to moderate risk category. And so of these patients, the health educators and the providers are spending most of their time providing those conversations through a brief intervention or positive reinforcement to patients that are scoring in the low risk category around, you know, how their healthy choices are making a difference. We are charged by SAMHSA with following up with 10% of the patients that score positive on the ASSIST screening tool. So I mentioned that we in Colorado use the ASSIST, the alcohol, smoking, and substance involvement screening test, that looks at tobacco, alcohol, illicit drug use, as well as the misuse of prescription medications. So that is the tool that we promote here in Colorado. And with the 10% that we followed up with over the first 5 years, what we found at follow-up interviews that are conducted by Omni with the patient is a significant reduction in the numbers of days of substance use, of reported substance use at 6-month follow-up interviews. And that's across alcohol, marijuana, and illicit drug use. You'll see the reduction here in terms of the numbers of days of reduction. So this is a huge success for us. What it demonstrated to us as a project team is that our services are really making a difference. And of course, this is patient self-report, but we look at this as a success. And so we're able to share this information with the settings that we work with to encourage them to continue doing SBIRT or to start doing SBIRT if they're interested in doing SBIRT. Because we know that it can really make a difference and improve the health care and the outcomes of our patients. Another approach to implementation that we have here in the state, I mentioned that we provide a lot of training and technical assistance to settings that are interested in implementing SBIRT, so that are not funded by us to implement SBIRT through the SAMHSA funds, but that are just interested or motivated to implement SBIRT for some reason. And so we go on site and we provide typically a 3-hour skills-based training, the rapid improvement activities I mentioned with the clinical guideline. We often have requests for motivational interviewing training. We did train the trainers here in our state. We've trained about 30 providers to be able to go on site at their institutions or their settings to train others to do SBIRT. Because what we know is that our SAMHSA support will not always be there. So we want to build systems in our state and encourage providers to take this on as their own so that it really does become institutionalized. We also recently, because our state, I mentioned, is mostly rural, we couldn't keep up with the demand or the requests for training. So we recently launched an online training. It's called the Substance Use SBIRTmentor. It's available nationally, and it's a 3-hour skills-based training available online 24/7. Providers can earn continuing education credits, 3 continuing education credits, and it's a very interactive training. So the provider is taught the skills of screening brief intervention, and then they're able to practice the skills that they learn through this training with simulated patients. So they're able to type in open-ended questions, for example, and if they type in something that would normally receive a defensive response from a patient, then the simulated patient comes back and says, "I'm not an alcoholic. Are you assuming I'm an alcoholic?" And then the provider gets a opportunity to correct that with another chance to put in an open-ended question. So it's very interactive, and our goal here was really to further our reach beyond what we could handle just in-person training. So it's available now, and there's a link. It's cmecorner.com. You might be able to read it on the bottom right, /SBIRTmentor, and we can send that out to you after this webinar. And there is a fee for service for this. It's $99, and it's available. That covers the continuing education credits that are available through that training. We also launched an online referral database. What we found with working with all of our healthcare providers over the years is even though there's a small percentage of patients that will be identified through the SBIRT process as needing substance use disorder treatment or mental health treatment, they still talked about the barrier of, well, if I do identify that 5 to 7% of patients through this process that needs treatment, I need a seamless way to refer them to treatment. I need it at my fingertips. I need it to take less than 5 minutes to identify a resource. And I need to be able to give this information to my patients so they're able to make that next step. So we launched an online referral database. It's called linkingcare.org. And it's a handy resource that healthcare providers can input information about their patients to generate a list of substance use treatment providers or mental health treatment providers in their community to make that next step should they need treatment. And linkingcare.org has, you'll see here, a way to put, you could put in the patient's address. So if it's in rural Colorado, you could put in the zip code or the street name, and then you could go on to put additional information that you know about the patient. Let's say we know the patient needs residential treatment, the patient is under 21, you could type in this information and submit. And this would generate a Google map with all the locations available to that patient for treatment, and also the provider could print a list of these licensed treatment providers to give to the patient as a next step. So this has really been a great resource for us. Omni Institute manages this out of their shop, and it's a great resource so that providers feel confident when they do identify people that need treatment with taking that next step and providing those resources. And this really aligns well with our goal that I mentioned earlier of building those relationships between healthcare providers and the behavioral health providers in our state. So I mentioned some of these, but I wanted to highlight some of the lessons learned from our 7 years now of implementation. The first is to know your community, but to implement universal screening. Oftentimes we'll go on site to a healthcare setting or an employee assistance program setting, and they'll say, well, we know the population that we need to screen. We know who those people are, and we have to kind of reframe that thinking. The goal here is really universal screening. The goal of SBIRT is not to identify people who need substance use disorder treatment or mental health treatment, but to identify the people that you often wouldn't know otherwise, that might just be slightly at risk. And we wouldn't know that unless we universally screened our patients. So really kind of helping the providers understand that the goal here is to identify the people that don't need treatment, to identify the people that can benefit from a brief conversation around changing behavior so that they don't ever become dependent or in those higher risk categories. So it's a little bit of a shift in thinking. The second lesson learned that's listed here is that SBIRT supports healthcare providers in meeting public health goals. It doesn't put them in the treatment business. Again, oftentimes we're having to educate providers about how the goal here is not to identify people who need treatment. It's really a population-based approach to educating around what the healthy drinking guidelines are or what the health risks are of any marijuana use. So really it's an opportunity to have these conversations with all of your patients no matter what risk level they're in. The third is to identify referral systems and resources for providers. This speaks a lot to that issue I raised earlier around building the relationships between behavioral health and physical health care providers. So we're really working to close that loop between the two and to help healthcare providers feel comfortable in knowing where to refer their patients that need additional services. The next is to improve quality of care is the primary motivator. So we did a lot of interviews with healthcare providers to see why are you motivated? Why is this important to you, this work of implementing SBIRT? Why is this making a difference? And most of our conversations revealed that it was the ability that SBIRT has to improve the quality of healthcare delivered to the patients. This is typically what we heard from the healthcare providers that we interviewed through this process over the course of our implementation efforts. The next is that patients are appreciative rather than resistant to the SBIRT process. We always hear from working with our providers is that I don't want to ask my patients this because I don't want them to become defensive. They're not going to tell me the truth anyways. They're going to underreport their alcohol use. Who am I to ask them about their substance use when I drink above the moderate drinking guidelines? That often comes up. But we really encourage providers, and we share this information with them, that patients actually do want to have these conversations. This is showing up in our data and our low refusal rate through our SBIRT work. Patients aren't saying, no, I don't want to talk about this. There have been concerns around what's being reported in the medical records and documentation and things like that. And we just try to address these issues with the healthcare providers so that they're able to have these conversations with the patients. If the patients do have questions around why are we being asked about our substance use, I'm here for my healthcare visit. So we really provide the healthcare providers the skills needed to have these conversations in a way that makes a difference with the patients. The next lesson is that patients reduce use after participating in SBIRT. You saw this in the data that I presented on the outcome evaluation that I demonstrated in a slide previously. And then regarding sustainability, we know that staff and institutional support is critical for success. And this is all staff within a practice. So we're talking everyone from the front desk to the billing department. And what we typically try to do here is when we go on site to do a training, we invite everyone from the clinic or everyone that's involved in the emergency department with the initial launch of the SBIRT program, so that everybody feels they have a role in this effort and they understand the benefit of SBIRT and how it will make a difference in the care they provide. The next is kind of a sticky issue. Reimbursement is not the answer. So we thought for a long time, probably the first 5 years of our implementation efforts, that as soon as we activated the Medicaid codes in our state so that providers could, provide this service and being reimbursed for it, that all of our dreams would come true, right? So this would become institutionalized because providers can now be paid for these services. Well, it wasn't that easy. We were successful in passing legislation, activating the CPT codes in our Medicaid, and to this date, we have very few providers that are billing for the services. We're doing a lot of kind of investigative work now to figure out why that is. What we're finding is that a lot of providers think that the time, that the 15 minutes and the 30 minutes or more that are associated with the codes, it's too much time. Or what we're finding is that providers are confused about who within their practice can deliver the screening and brief intervention services in order to be reimbursed. Is it a health educator position? Is it a nurse? Is it the physician? Is it a collaboration of the whole team? And does the whole process from the brief screen to the referral to treatment count for the 15 minutes? So there's a lot of questions around the reimbursement piece, and that has not solved all of our problems here. The next lesson learned, policy impacts the delivery of services, and you'll hear from Jen shortly around the marijuana protocols that we've recently implemented in our SAMHSA-funded sites. That legislation happened just this last legislative session, the end of last year, and so marijuana is now legal for recreational use for adults 21 and over, and so we quickly revised some of our screening protocols so that we could better identify marijuana use among our patient population and provide the necessary brief intervention and education around the health risks associated with marijuana use to every patient, regardless of what the use is for medical or recreational purposes, and any use. So we're really treating marijuana use similar to how we do with prescription medications. We know that a lot of patients we're finding are using prescription medications outside of the way that they were intended, or they're using somebody else's prescription, or they're using a prescription that is out of date. And that's an opportunity to have a conversation with a patient as you're providing these screening and brief intervention services. The other, women of childbearing age, which Jen is also going to talk about in a minute, we partnered with Project Choices in our state to revise our screening and brief intervention protocols to really capture women of childbearing age who may not be using effective means of contraception and who may be drinking. And that's an opportunity to have a different kind of conversation, because that woman may be at risk of having an unintended pregnancy and then drinking maybe not knowing that she's pregnant. So how can we have a meaningful conversation around the risks associated with drinking while not using effective means of contraceptives, or drinking during pregnancy? So when we do identify women who are pregnant and who are drinking, what are the additional risks around that, and how do we train providers to be able to address that issue differently than the general population? So we've revised our protocols pretty significantly to address these special populations. And I think that speaks to the last lesson learned here. A key to sustainability is partnering across programs. So we've really identified a lot of resources in our state, such as the Project Choices work that's going on, to really look at the prevention of fetal alcohol spectrum disorders. And we worked with Dr. Pam Gillen, who's our FASD fetal alcohol spectrum disorder statewide director, to identify what can we take from your program to further enhance our program so that we are addressing the needs of our community and our population so that we can have these conversations and continue our work with the SBIRT program with the help of the experts that are available to us. So with that, I think I'm going to pass it back to Tracy, and we can open it up for questions if there are any, and then Jen will jump into the SBIRT protocols and how we've revised it to meet the needs of a couple of special populations in our state.
Great, thank you, Bree. Yes, we do have a couple of questions, and I encourage folks to use the questions chat box to type in their question, and we'll try to answer a few of those. And if we have any time left over, again, we'll try to come back to any that we aren't able to address. So the first question, Bree, is, can linkingcare.org be used in any state or just Colorado?
That's a really good question. Right now, the data set that's incorporated in Lincoln Care is just Colorado specific. So they're all of our licensed treatment providers in our state. But that doesn't mean that Omni they might be able to assist you in building a similar database. We can give you the contact information for the people at Omni that can help you with that.
That would be great. Thanks, Bree. The next question we have is, does SBIRT hold an abstinence is best position, or is there a focus on harm reduction for people who continue to use alcohol, tobacco, and other drugs?
So I can speak to Colorado's SBIRT initiative. We are not an abstinence-based program. So we really educate, we look at substance use as a healthcare issue, and we educate patients around potential health and other consequences related to really any use, and then encourage them to make healthy behavior changes. But for example, if a patient reports drinking above the moderate drinking guidelines, the healthcare providers can have a meaningful conversation about just reducing to within those healthy drinking guidelines. So if a woman reports drinking above 7 drinks in a week, let's say she's drinking 13 drinks a week, and then the message could be, you know, if you cut down within these guidelines, you could reduce your chance for health-related consequences. Having said that, there are some people that no alcohol use is the right message for them. For example, people under the age of 21, our message is no alcohol use is appropriate for that age. Or people that have struggled with addiction. Sometimes our message with those patients, oftentimes, actually, the message is no alcohol use is safe. The best is not to consume alcohol. Drug use, illicit drug use, our message, of course, is that there is no safe amount of drug use or tobacco use, and then encouraging and working with the patient to really identify their own goals. What goals does the patient have, and working with them to meet their goals that they set for themselves. That's really our approach, because we really incorporate the motivational interviewing concepts, and it's really meeting the patient or the client where they're at and then developing their own plan for change.
Great. Thanks, Bree. And another question we have is what are the screening questions for marijuana use? Are they built into the assist tool that you mentioned earlier, or are you using a separate screening tool?
That's a great question. So we are adding to the brief screen to our process, in the past year, how many times have you used marijuana? Any reported use on that question would indicate the need for further screening. The assist does look at marijuana use, so it would be captured there because we use the assist. If a clinic or a hospital chooses to use the audit or the audit and the DAST, it would also be captured in the DAST, the drug abuse screening test. So there are tools out there that would identify risks related to marijuana use. Right now we're just in the mix of working on a marijuana supplement to go along with our SBIRT clinical guideline that I showed you earlier that will really train providers in how to further address marijuana use should it be reported by patients. So what information to incorporate in a brief intervention.
That's great, Bree. We're definitely looking forward to seeing that. We've seen the the one on the prescription medication misuse that you've developed with Health Teamworks, and that's also terrific. So I'm looking forward to the one that addresses marijuana. Let's see, we have a couple more questions. Is there a link to the SBIRTmentor training program that you mentioned that you had a slide on? Do you have the URL to that?
I do. I wonder if I can, or Tracy, or if we can put it in the, type it in here. Would that be helpful?
Sure, absolutely.
Okay. Let me see if I can do that.
All right. No, I can do it. I think I remember the web address. Yes, I believe I do. I will read it off to folks while I try to type it into the box. It's CMECORNER, which is cmecorner.com/SBIRT, and that's SBIRT. So cmecorner.com/SBIRT.
Thank you.
And Misty, if you're able to type in that address, that would be great. Thank you. And we'll take one last question here. And let's see. Let's see what we have here. Was any data collected regarding those who rated as high risk? If so, what were the results of SBIRT with that population? And this may be something that Jen's going to get to. So if you need to defer, that's also fine, Bree.
I might defer that one to Jen. The slide that I showed you of our outcome data was representative of patients that scored in the moderate risk category and above. So anybody that scored in the assist as being in the moderate risk category or above. So that would include people in the high risk population. One interesting lesson learned, I guess, is that we're trying to do a better job of also collecting data on the people that are referred to treatment. So of the patients that we refer to treatment, how many people are showing up, to how many sessions are they showing up to, and just capturing that as well. And what we've noticed so far is that people are still falling through the cracks, and whether that is because of due to their level of motivation of engaging in substance use treatment, or if there's something that we're missing in terms of providing the patient adequate resources to really make that next step. So we're really trying to assess that and to improve that linkage as well.
Great, thanks, Bree. Well, we will have a couple more. We do have a couple more questions, but I think we're going to hold off and we're going to pass the baton over to Jen Shepard. But let me first introduce Jen to everyone. It's my pleasure to introduce Jennifer Shepard. Jennifer is an evaluation researcher at Omni Institute. She received a doctorate in social psychology with an emphasis on health from Iowa State University and completed a 2-year postdoctoral fellowship at the Partnerships in Prevention Science Institute. Jen leads several evaluations of health promotion strategies and interventions targeted to both youth and adults, as well as a team that develops data dashboards. Jen is the lead analyst for the SBIRT Colorado evaluation and is also a member of SBIRT Colorado's leadership team and policy steering committee. So join me in welcoming Jennifer Shepard. And I'll pass it over to you, Jen.
Thank you, Tracy. I'm very excited to be here and share some of our data with you all. So as the analyst on the evaluation team, that means I get the fun job of getting to play with the data, some of which I'll be sharing with you today. Specifically, I'm going to be talking about some of the data related to populations that we've taken a special interest in, marijuana users and women of childbearing age. But before I get into those specifics, I wanted to give you all an orientation to our screening data, just more generally, and then a little bit more about some of the screening tools that we use just to kind of ground us all before we get into the specifics. So what you're seeing now on your screen, I hope, is our data dashboard. So we are very excited about this. This is something that we have developed for our stakeholders and each grant-funded data collection site also has a dashboard that has just their data. And these are interactive, and the dashboards are available online, and the data are updated in them monthly. So the data you're seeing now are through the end of July. And so this dashboard that you're looking at is the aggregate dashboard that has data from all of our current grant-funded data collection sites. In the slides, which I think you have also received, there is a link to the dashboard from our previous grant effort, the first 5 years that Bree mentioned. So just quickly here, I wanted to just show you some of the features of this dashboard. So you can see here in the upper left that we've screened over 14,000 patients to date with our current grant. And you can see the proportions that were positive, meaning they screened at that moderate risk level or higher in each year versus the negative. And then this table below is for each of the substances measured by the assist. So here's the 10 substances that the assist measures. And then the prescription drugs comes from the GIPRA. So you can see our rates for across the entire grant collection period, and then you can also use the menu to look at a specific year. And since we just started, we don't have a lot of data in here yet, but we do have what we have so far in 2013. And then our upper right lets you see across all the substances that we screened for, you can see which proportion of patients screened at each of these risk levels. You can see that so far we've had 5% screen at that high risk level and 3% at moderate high and so on. And then you can also look at that by specific substance on the assist. So if, for example, if you're interested in tobacco, somebody could click on there and see what those risk levels look like for tobacco. And then in the bottom right, we have the demographics of the patients we screened through SBIRT Colorado. So we have just all patients screened to date. We have by gender, by age group, and by race ethnicity. And then on the right, you can look at those same demographic groups, but this time looking at the interaction of risk level and substance. And you can just see how those change. So again, we're very excited about these. Our stakeholders enjoy coming in here and looking at some trends. And these are available to the public. They're only our SBIRT Colorado data, but any of you could go to the website that is shared in the slides and play with these data if you're so inclined. And now let's get back to our presentation. So there's the links there. So before I get into the specifics about those two specialty populations, the marijuana users and the women of childbearing age, I just wanted to make sure that everyone was familiar with the tools that we use for SBIRT Colorado, because I know people implementing SBIRT use different tools. Bree mentioned a few of them, the DAST and the audit and the CRAFT. And so I do apologize for those of you who are already familiar with the assist or the GIPRA. I do promise I will not walk you through each and every item. I just want to make sure you know what questions are being asked of our patients that resulted in the data that I'm going to be sharing with you. So here on the screen you see our brief screen items. And the way this works in Colorado is that someone at the clinic or hospital, not necessarily the health educator, will administer the brief screen, or the questions might even be part of an intake form that a patient could complete on their own. And at most of our sites, there is no further action taken with patients who report that they do not use any of these substances. But if a patient does screen positive, then the health educator will administer the ASSIST, the Alcohol Screening and Substance Involvement Screening Test, to further assess their risk level. So positive means that if it's a woman, they've had more than 7 drinks, or if it's a man over 65, more than 7 drinks per week. If they're a man under 65, that's 14 drinks, if they drink more than that per week. For women and men over 65, if they've had 4 or more drinks per day in the last 3 months, that's positive. Or if they're a man under 65, 5 or more drinks per day in the last 3 months. Or if they say, yes, they have used an illegal drug in the past year, or they smoke, or they have a medical marijuana card. Any of those things is considered to be a positive screen, and then they will get the full screening tool. And as Bree mentioned, we did recently add another question to our brief screen to further differentiate between recreational marijuana use, which will soon become legal in Colorado, from illegal drug use. So that question is now part of our brief screen, but is not part of the data I'm presenting today, and that is, in the past year, how many times have you used marijuana? So that is our brief screen. And then looking at the assist, oops, sorry, slide got ahead of me there. Looking at the assist, patients are asked, in your lifetime, which of the following substances have you ever used for non-medical use? And then the assist asks about 10 different substances. And for each one, our health educators give some examples to the patient. So you can see here I've listed out the examples for alcohol and cannabis. And then the same is true for the other 8 substances that you see listed there. And then for every substance the patient says they've used in their lifetime, they're asked if they have used that in the past 3 months and how often they have used it. And you see the response options there. And then in addition to asking about their frequency of use, the assist also collects data on consequences of use. So you see the consequences here, or at least all but that last one. Sorry about that. So their patients are also asked if they've had a strong desire or urge, if their use has led to consequences, if they haven't done what's expected of them, if others express concern. That last item is, have you ever tried to cut down on using whatever substance they've been using but failed? And so these items are scored according to the World Health Organization, and then the patient's risk level is determined based on that score. And then our patients who are screened through the SBIRT Colorado grant-funded initiative are also asked questions from the GPRA, the Government Performance and Results Act. And so the GPRA asks about more recent use, so 30-day use, if they've used alcohol, drugs, both on the same day, and how many days in the past 30 they've used each of the substances. And so the results that I'm going to share with you now do include data from these GPRA questions as well as the assist questions, but trust me, there are many, many more questions on the GPRA that we could present about, but we're going to stick to these ones for today. So let's talk about our first specialty population, marijuana users. As Bree mentioned, marijuana was recently, well, I should say an amendment was recently passed for marijuana to be legal for adults. Medical marijuana was first legalized in Colorado in 2000, but it really took off in 2009 when the U.S. Attorney General said that federal agencies would not raid medical marijuana dispensaries. And shortly thereafter, the Department of Public Health and Environment here in Colorado was receiving 1,500 applications for a medical marijuana card daily. So there were a lot of people interested in medical marijuana. And then that legislation just passed recently for the recreational use of marijuana, and it's expected that those regulations will take place January 1st. And so we here at SBIRT Colorado are in a great position to document what happens when all that sorts out, and we are very interested in monitoring those trends in marijuana use and marijuana risk. But for today, I'm just going to be reporting on trends in medical versus illegal marijuana use because we don't yet have the data for the legal. So we had several research questions around this population of marijuana users. First of all, we just wanted to know how many of our patients were using marijuana, what proportion had a medical marijuana card, does their use differ depending on where they're getting their marijuana, although I do need to point out here that we do not actually have data on where they're accessing their marijuana. We're just assuming that if they have a card that they're obtaining it through the medical marijuana program, meaning a dispensary, as opposed to from their friend or whoever. So we're just making that assumption here. And then we're also interested in knowing, do our marijuana users use other substances? So those are our questions. So first let's look at our prevalence of use. So you see on the slide here that about 35% of the patients we have screened so far in SBIRT Colorado have used marijuana in their lifetime. About 15% had used it in the past 90 days. About 10% were using it daily or weekly. And we also were interested in knowing how many people had medical marijuana cards. And you see there that as of the time we pulled these data, which were at the end of April, 308 of our patients screened had a card. 8.6% of people who had ever used marijuana had a card, and 19.1% of people who had used in the last 90 days had a card. Now again, this might be a good time to remind you that these are just patients screened through SBIRT Colorado. This is not necessarily representative of Colorado residents in general. I think those would be some very interesting data to look at, but all we're able to speak to here are the patients screened in our healthcare settings. And if you're wondering a little bit about who these marijuana users are, I can tell you that of people who used in the past 90 days, those who had a card were 62% male, or I should say 62% who had a card were male, and that's about the same for those without a card. Cardholders were age 39 on average, whereas non-cardholders were 36. And our cardholders, 57% white, whereas non-cardholders, 53% white. So fairly similar in terms of their demographics. Next, we looked at the frequency of use, and we saw some striking and even statistically significant differences here between our marijuana users who had a medical marijuana card versus did not. So you'll see that of the people with a card, over 60% of them reported using marijuana daily, compared to less than 40% of our non-card holders using daily. Cardholders were also using more days out of the past 30 than non-card holders, so 19 days versus 13 days, and that was statistically significant. So we definitely saw a difference in their amount of use, or I should say frequency of use. And then we also wanted to look at the risk level of those marijuana users. So we found that our cardholders were more likely to screen positive for marijuana use, so meaning at the moderate risk level or higher than non-card holders. So 90% of cardholders screened at that BI level or moderate risk level compared to just under 70% of non-card holders. However, cardholders were more, although cardholders were more likely to be at risk for marijuana overall, non-card holders were more likely to screen at the higher risk levels. So whereas only 3.2% of cardholders screened at the moderate, high, or high risk, or might be more familiar to you in brief therapy or referral to treatment levels, 7.1% of our non-cardholders screened at those levels. So that was a very noticeable difference there. And it might be important here to talk a little bit about the assist scoring. So weekly use of a substance on the assist will automatically classify someone at the moderate risk level, even if they're not reporting any other consequences to their use. Just by saying they use that frequently, they're automatically classified as moderate risk. So it's not necessarily the case that cardholders are experiencing more consequences, and that's why they're screening at that moderate risk. It may just be because of their amount of use. And I'll say a little bit more about that in a minute. And then finally, we were interested in seeing if use of marijuana co-occurred with use of other substances. So are our marijuana users also using something else? And as it turns out, they are. So of the people, our patients, who had used marijuana in the past 90 days and were using at a level at least at the BI and above, so they screened positive, you see here that 43.1% of them were also using alcohol at least a BI level or above. So they also screened positive for alcohol. 71.9% also screened positive for tobacco. 6.8% screened positive for stimulants. And then you see cocaine and opioids there as well. So generally, our marijuana users were positive for multiple substances. And also notable and very interesting to us is that it was our non-card holders who were more likely than cardholders to screen positive for alcohol, tobacco, and stimulants. And you see the exact values there on your slide. Now, it's not the case that they were not more likely for the other substances measured by the assist. It's just that our sample sizes were a little too small for those less used substances to be able to test that yet, but we will certainly be keeping an eye on that. So what have we learned so far about our marijuana users? Well, we have learned a few interesting things. So we know that at least so far, it appears that our medical marijuana cardholders are more likely to be at risk for marijuana, specifically at that moderate risk. And we think that might just be due to the fact that they're using frequently. Remember, 60.5% of our marijuana cardholders were reported using marijuana daily. However, non-cardholders were more likely to be at a greater risk for marijuana and also more likely to screen positive for other substances, specifically alcohol, tobacco, and stimulants. So we weren't necessarily expecting these results, but we're finding them very interesting to start looking at these patterns of use for people who have a marijuana card versus do not. And we're very excited to see, as our data come in on our additional marijuana question, and start differentiating even further about people who have a card even after the legalization and whether they're using it that way or not. So we look forward to being able to do some more analyses and explore our data in further depth as this legalization pushes its way through. So I'm going to take a little pause here, take a drink, so we're going to shift gears into our other specialty population. And next I'm going to be talking to you about women of childbearing age. So as Bree mentioned, we've been working with some other partners and share their interest in preventing alcohol-exposed pregnancy. And so we've decided to just take advantage of this opportunity that has been offered to us by having the SAMHSA grant and working through SBIRT Colorado to ask patients about related topics that are of interest to us and our partners and other stakeholders. And one of those topics is preventing alcohol-exposed pregnancy. Now, I will mention here we did recently expand our criteria in our screenings to include other substances. So if a woman is using something other than alcohol, we will also talk to her about her contraception use. But the data I'm sharing with you today, these results are based only on people who initially screen for alcohol. Although, as you'll see, that does not mean that's the only thing they're using. So first, let's look at this population and define them. So we wanted to know what proportion of women of childbearing age who are being screened in these healthcare settings through SBIRT Colorado are sexually active, are not using effective contraception, or at least not using it all the time, and are using alcohol. And we also wanted to know if they're using other substances. So our protocol in working with this population is if the women are 18 to 44, between those ages, and they screen positive for alcohol on our pre-screen, or also known as the brief screen, or if they were indicating any alcohol use on the assist, then our health educators were asking them some additional questions about pregnancy and contraception that our other patients are not asked. And just as a reminder, positive on our brief screen means that these women were drinking more than 7 drinks in a week, or they had consumed 4 or more drinks in one day sometime in the past 3 months, or they had used alcohol in the past 3 months on the assist. So any of those would be considered a positive screen, and they would get these questions. So these are questions. Our women patients in those age groups are asked, are you pregnant? Are you able to get pregnant? In the last year, have you had sex with a male? When you have sex, do you use something to prevent pregnancy all the time, most of the time, sometimes, or not at all? And for those who are using some form of method to prevent pregnancy, they're asked to tell us which methods they're using. Now, at this point in the screen, the patient is just telling the health educator which methods they're using, and then the health educator is marking them in our database that Bree mentioned, and then that's where the health educator can see if they're effective or not effective. Those designations are based on that Choices Project through the CDC. It's not that the patients are telling us how effective their birth control is or their contraception is. And then if a patient indicates that they are not using birth control 100% of the time, and we already know that they're drinking and are of childbearing age and they're able to get pregnant, at that point, that's when our health educators will give them some information about their risk and tell them that no amount of alcohol is considered safe during pregnancy, and that pregnancy should be delayed until you're alcohol-free. And then the patient's encouraged to speak with their provider if they were considering becoming pregnant or have any questions. So we do not expect our health educators to get into an in-depth conversation about this with our patients. We just have not trained them or expect them to know all there is to know about effective birth control. But we do want to at least start that conversation. Excuse me, I'm losing my voice here. We do want them to start having that conversation and at least plant that seed that they could talk to their healthcare provider, and hopefully they do so. So you can see here that we have had just over 1,500 women in that age group, and most of them did not screen positive for alcohol, meaning they did not receive the additional questions. But almost 300 women were eligible for the contraception questions. And of those 297, 170 of them had been sexually active with men in the past year and were also able to get pregnant. And so that 170 is the sample that I'm going to be discussing with you. So just a little quick look at their demographics. So I highlighted 2 here because they are noticeably different between our just general women of childbearing age population compared to the more reduced sample of women of childbearing age who are using alcohol and are able to get pregnant. So you see there that whereas women who are Black African American only make up 5.3% of our total women of childbearing age, they are 14.7% of our sample of women who received our contraception questions. And in contrast, Hispanic Latino women are more represented at 40.5% in our overall women of childbearing age group as compared to those who received our contraception questions. And that's mostly due to their alcohol consumption. Non-Hispanic women of childbearing age are more likely to drink than Hispanic women, and the opposite is true for Black or African American women. So we were quite surprised when we looked at these data for the first time and saw that of our 170 women who were asked about contraception, that so many of them were using ineffective contraception. You see there 72.4% were using ineffective and 3.5% were already pregnant, meaning only 24.1% of our sample was using effective birth control. Now, I do want to point out here that we were being a little conservative in our categorization of effective and ineffective, in that if a woman reported using both methods, we are counting her among the ineffective group because we were not able to ask, due to time constraints, how consistently women use each of the methods they report using. So it's possible that a woman who said she was using an effective method, such as the pill, and an ineffective method, such as a male condom, if she used both of those 100% of the time, she would still be counted here as ineffective. So I do want to point that out about our data, just a conservative approach, because we're not entirely sure how often they're using each method, if they're using more than one. So we definitely had the high-risk women here, or at least I should say at risk for an alcohol-exposed pregnancy. And then when we looked at how frequently they were using some form of contraception, you can also see that they were not using it very consistently. Only 12.2% reported using contraception all of the time. And it's much more common that they were using it not at all or only some of the time. When we looked at other substances used by these women, so remember they've already said they're using alcohol, so it's no surprise there that our alcohol use in the past 90 days is so high. You might wonder why it's not 100%, and that's just one of the interesting things about collecting these data. Sometimes anomalies will show up where they'll report use on one measure and not on the other, and we don't really know what to make of that, but we just move on. So you can see that in addition to alcohol, many of these women were also using tobacco. 71.3% had used tobacco in the last 3 months, and over 60% were using it daily. And marijuana was being used by 15.5% of these women on a daily basis. So when we looked at women who were using more than one substance, we found that quite a few of them were using 2 or more substances. 79.1% had used alcohol and something else in the past 90 days. 45% were only using 2, but 24.8% were using 3, and 9.3% were using more than 3. Only 20.2% of our sample of women of childbearing age who were able to get pregnant and were having sex with men were using only one substance. So there's a lot of polysubstance use here. And then when we looked a little more specifically at how often they were using these substances, you see here past 90-day alcohol use. Many of them were using it at least weekly, even daily and monthly. So certainly opening up the opportunity for them to have an alcohol-exposed pregnancy if they're drinking that frequently and having sex without ineffective contraception. Similarly, tobacco was being used frequently, most of them using daily, and then less likely to use it just once or twice or monthly or weekly. They generally using it never or daily. And then looking at marijuana use, you see that of our marijuana users, about 40% were marijuana users. 10% or so were using it just once or twice, 6% monthly, 9% weekly, and then 15.5% were using that daily. So we learned a few things here as well. We learned that it's definitely very important to ask women of childbearing age about their substance use and contraception practices. So in our sample, at least to date, over 3/4 of them were using ineffective contraception or were already pregnant. As I showed you, contraception use was pretty irregular. Only 12.2% were using something all of the time, and what they were using may not have been an effective method. All of these women were using alcohol, and that is a known teratogen that can have very negative and serious consequences on fetal development. Most of these women were using 2 or more substances, and they were using it recently. So this is within the past 90 days, especially alcohol and tobacco. So I just wanted to wrap this up by saying that SBIRT Colorado has really provided us with this wonderful opportunity to look at these specialty populations, including marijuana users and women of childbearing age. And so it's our hope that these data and those we're going to be collecting throughout this project will help inform prevention and intervention efforts here in Colorado and maybe in your state as well. And we're also really excited to be able to start looking at our 6-month follow-up data. So Bree shared with you some of the results from our last grant where we saw significant reductions in use. And so we hope to see that our patients reached through this SBIRT Colorado grant have also reduced their use. We did have those wonderful results last grant, and we're hoping for a repeat performance. So as we say around here, SBIRT Colorado is improving health and changing lives, and we are very grateful to be part of that. So thank you all very much for your participation today, or I guess we were doing most of the work, you were just listening, but we do thank you for attending, and thank you for inviting us. Tracy, I'm going to turn it back over to you for questions.
Great, thanks, Jen. And we want to open it up for questions. We have a few minutes, and I want to encourage folks to use their chat feature in the questions portion of their go-to webinar control panel. I have one question for you so far. Why did you combine daily and weekly use of marijuana? So I think this came in early during that portion, so I don't know if you need to refer to that data. Of course, being an analyst, you probably have this all on the top of your mind, but let's combine the daily and weekly use into 10.3%. I'd like to know daily use as an independent measure and the incidence of combining marijuana with benzos and or opiates, especially among cardholders. I don't know if you sliced and diced the data that way, or if this might be something you need to follow up specifically with this person. We could certainly put you in touch. But any thoughts on that?
Yeah, I would have to follow up. We didn't combine the daily and weekly use of marijuana, if I think I understand the question correctly, for everything that we do. Just for this particular slide, we put those two together. But we definitely have the data separately and could look at it that way. And same with opioids. We could look at the co-occurrence of opioid and marijuana use. Just so few of our patients had used opioids that we weren't able to do statistical testing yet, but that doesn't mean we don't have some numbers on that. So yeah, I'd be happy to share those if the question asker is interested.
Great. So I would say that following this, we're going to have Jen's contact information and Bree's contact information on the last slide, and the slides are posted to the website. So for the person who, Ms. Stewart, who posed that question, feel free to contact Jen directly. I have a second question. Just make sure I understand this correctly. If points are used, so patients, okay, if patients are using medical marijuana, what approach do you take? I am delivering SBIRT services in Wisconsin. So is there a specific approach? I think we're talking about specifically with the brief intervention. Not quite sure, but I think that's what it is. There's a specific approach or perhaps model that you take with medical marijuana that may be different for non-medical marijuana use. And this could be for Bree or Jen.
Sure, I can tackle that one. I think we're still trying to figure that out. So we still take it as an opportunity, medical marijuana use, to educate around what the health consequences are, potential health consequences are related to marijuana use. I think we're still learning a lot, and through this work with developing the marijuana supplement, which we'll make sure you get a copy of once it's finalized, is that because there's not like a recommended quantity frequency around marijuana, some of these things haven't been figured out yet, and a lot of the information isn't out there. So we're still just saying, you know, this is an opportunity to have a conversation about what it means to inhale marijuana or ingest marijuana and the potential consequences based on the science and the research that we know around the health consequences. So we can't recommend like moderate marijuana guidelines because they're not established yet. So we are struggling a little bit with that. And I think also looking, I had a call just today about how does marijuana interact with other medications, and trying to figure out, you know, what information there is around that. Or people living with HIV, maybe they are taking marijuana for certain health concerns, health issues, but how is that affecting their immune system? You know, all of these issues that we're trying to really identify the best way to approach the brief intervention. So not a clear answer, but as we plot along, we'll share what we know.
Great, Bree. Thank you so much. We have another question here. Any idea if data was collected on how many of the women in the sample were employed at the time of the screening?
We would have that information for those who screen at a high enough level that they were asked GPRA C through G, so GPRA module C through G. I believe that gets into employment, but that's obviously a reduced amount of our sample since only those who screen at the BI level or above are asked those questions. Or actually, I should know this, but Bree, is it BI level or above or BT level and above? I believe it's BI.
For GPRA B?
GPRA C through G.
Yeah, so that would be referral to treatment.
Okay,
so it
only
is a
small proportion. Mm-hmm.
Okay. We have someone has asked where they might be able to find copies of the Assist and the Craft and other tools, and we're going to make it easy for you. I'll work with Misty, who will be where she posted the copy of the slides. We'll post links to those tools as well, so that you can, I think they basically pop up and give you a full PDF copy. And they're nice color forms so that they're sort of ready for you. So we'll make those available to you. And let's see, we're getting very close to the end of the presentation, and I think what we're going to do is wrap up. And I would say if we haven't gotten to your question again, both Bree and Jen have been very generous in both their time today in sharing their experience, but also are certainly willing to follow up with you any questions you might have. I'd just like to thank Bree and Jen very much for joining us. I have to say these have been, we are really excited about both of these topics. We get a lot of interest when we do presentations and trainings and workshops in TA about these two specific topics. I think it's a growing and emerging area within SBIRT. And we hope to offer more webinars on this topic. In fact, at the end of this month, we'll be having a webinar with Paul Seal, and he'll be talking about marijuana SBIRT and the protocols that they use. A few months ago, Nancy Goller out of Kaiser Permanente did a presentation for us about an early start program working with pregnant women, and folks can already go to that. It's archived and readily available at the hospital Big Initiative website, which is hospitalsbirt.webs.com. So that's available to you right now. And coming up in, I believe, in December, so keep going to the National SBIRT ATTC website. There is a longer address that I can't remember off the top of my head, but the one that I can remember is ireta.org/SBIRT for the coming events. And one of those in December will be Carolyn Swenson of Health Teamworks, which you know is a partner you've heard today, and she'll be talking further about some of this as well. So I want to thank everyone for your participation, and just mention to you that following this webinar, you're going to be receiving an email with an evaluation, and I can't emphasize enough to you how important it is to get your feedback. It's extremely critical to the success of our program and for really hearing from you about how we're doing and how you might be able to use this information in the work that you're doing. So please, I can't emphasize enough the value of that evaluation. So thank you, Jen. Thank you, Bree, for joining us. And thank everybody for your time today.